Many years ago, approximately 13th century BC, during the Trojan War, there lived a valiant warrior named Achilles. And as he was driving the Trojans back, he was shot in the ankle with an arrow, and he died. It was believed that he was immortal, except for the weak points around his ankle, because his mother had dipped him in a river that made him immortal, but she hadn't immersed his ankles because she held him by his heels. But enough about this Greek mythology. Today we're talking about Achilles tendon ruptures. Don't worry, you won't die.
How common is Achilles tendon rupture? Achilles tendon rupture affects competitive and recreational athletes, as well as those who are less active. According to UpToDate, the incidence in the general population is 5 to 10 per 100,000. 80% of ruptures occur whilst playing sports. Having had a previous Achilles tendon rupture also predisposes you to developing it, with 10% of ruptures having had previous problems. Competitive athletes have a lifetime prevalence of 24%, and in competitive runners, the prevalence is much higher at 40 to 50%.
Rupture of the tendon commonly occurs when sudden shear stress is applied to the tendon. This usually happens with a rapid change of direction, such as cutting during a basketball game, or rapid pivoting, or rapid acceleration. This also commonly occurs with tennis players and runners.
Initial management of the rupture includes resting the tendon by using non-weight-bearing aids, applying ice to the affected area, administering sufficient analgesia, which is usually simple, such as paracetamol. The ankle should be immobilized in plantar flexion with a splint. And last but not least, the patient should be referred to an orthopedic surgeon for further management.
Patients with Achilles tendon ruptures will often complain of hearing or feeling a loud pop, coupled with severe acute pain. They may also describe feeling like they've been violently struck at the back of the heel. They are often also unable to ambulate due to the loss of plantar flexion, but do not be fooled. Some patients can plantar flex or ambulate if they have good use of the accessory muscles. This includes tibialis posterior and the peroneals. On examination of patients with Achilles tendon ruptures, on inspection, one will often see swelling, as well as loss of the normal shape of the heel. On palpation, tenderness is often present, as well as a defect in the tendon. And when asking the patient to plantar flex, they are often unable to do so. But however, as mentioned earlier, they may be able to plantar flex if they have good use of accessory muscles. But the most sensitive and specific test to determine the presence of an Achilles tendon rupture is the Thompson test. This test includes, while the patient is lying prone or kneeling on a chair with their feet hanging off the bed, the examiner will squeeze the gastrocnemius belly and watch for plantar flexion. If there is absence of plantar flexion, this indicates a positive Thompson test, which suggests Achilles tendon rupture. Special investigations include ultrasound and MRI, but more often than not, clinical examination is enough to diagnose an Achilles tendon rupture. These special investigations are only required if there is still high clinical suspicion and no confirmation on clinical exam or planning for surgery.
What is the long-term management of Achilles tendon rupture? The treatment preferred depends on whether it was a complete tear or a partial tear. You can either go the surgical route or choose to go non-surgical. Firstly, surgery is preferred in young, healthy, and active patients, such as athletes. The tendon can then be repaired using a closed or an open technique. After surgery, a short leg cast or boot is applied to the ankle. There is a decreased risk of re-rupture with surgery, and individuals can return to activity faster than without. Non-surgical treatment is indicated in older, inactive, and high risk for surgery patients. This treatment involves applying a short leg cast to the affected leg with the foot in a plantar flexion position. The leg is placed in this cast for 6 to 10 weeks with no movement of the ankle allowed. Walking is only allowed on the cast after 4 to 6 weeks. After removing the cast, A small heel lift is inserted in the shoe for 2 to 4 weeks whilst undergoing physical therapy.
Prevention of Achilles tendon rupture is possible by general and specific measures. General measures include warming up before exercise with dynamic movements, avoid training in cold weather, stretching during warm-up sessions or after training, and generally weight loss to reduce strain on the lower extremities. A very important specific measure is avoiding the use of fluoroquinolone antibiotics or reducing training volume and intensity at the start of fluoroquinolone antibiotic use. The most common complication of this is re-rupture. However, further complications exist in the surgically treated group. These include infection, abnormal sensation due to sural nerve injury, adhesions, and deep vein thrombosis.